Hello everyone, welcome back to my channel. So in this video we'll be talking about verrucous carcinoma. So verrucous carcinoma is also known as Snuff, Dipper'S cancer or Ackerman'S tumor. So it is known as Ackerman'S tumor because it was named by Ackerman in the year 1948. So now coming to the definition of verrucous carcinoma. So verrucous carcinoma is a white variant of squamous cell carcinoma which is characterized by a predominantly exophytic overgrowth of well-differentiated keratinizing epithelium with locally aggressive pushing margin. So in the definition what we see it is a variant of squamous cell carcinoma and it is characterized by exophytic growth. It is characterized by exophytic growth, like just like we can say cauliflower like appearances. We will see here, we will see overgrowth of well differentiated keratinizing epithelium. So in the squamous cell carcinoma we have seen well differentiated, moderately differentiated, poorly differentiated. So in this variant, it is in the verrucous carcinoma we will see overgrowth of well differentiated keratinizing epithelium, and this epithelium will have a locally pushing margin. So basically verrucous carcinoma, it is a white variant of squamous cell carcinoma and it is characterized clinically by a cauliflower like appearance, and histologically we will see well differentiated keratinizing epithelium, and this epithelium have locally aggressive pushing margin. So it represents 1 to 10% of all oral squamous cell carcinoma. So in this photograph what we see on the lateral border of the tongue, we can see cauliflower like appearance. We can see it is appearing as a whitish lesion, means keratinization we will see exophytic growth. So what is the etiology? So it is associated with the use of chewing tobacco or snuff. Okay, it is also associated with HPV subtypes 16 and 18, that is human papillomavirus, and it can also be caused by ill-fitting dentures. Now coming to the clinical features, age, mostly 60 to 70 years people, that is the mean age. Males are more frequently affected than the females. Site, mandibular vestibule, buccal mucosa, height, palate. So these are the most frequently seen sites where verrucous carcinoma usually occurs. So clinically it appears as a diffuse, well demarcated, exophytic, painless, thick plaque with papillary or verruciform surface projection. So as we have seen in the picture, so it is appearing, see in this picture what we can see, it is appearing on the lateral bottom of the tongue. We can see papillary surface, we can see exophytic surface, we will see it is whitish in color, means more amount of keratinization we will see. Okay, these lesions are white but they may also appear erythematous or pink. So sometimes erythematous or pinkish area can be seen. Another feature is Rogel-like folds with deep clefts in between them. So we will see the cleft present in between these papillary surfaces, means Rogel-like folds we will see between these clefts. So we can see another picture where we can see verrucous carcinoma which is occurring on the buccal mucosa. Here also we can see cauliflower like appearance, exophytic papillary growth we can see. So cervical lymphadenopathy presents attributed to the inflammatory changes. So in the patient we will see cervical lymphadenopathy. There is no nodal metastasis. Okay, it can develop from high pre-risk or proliferative verrucous leukoplakia. So verrucous carcinoma usually it can occur from proliferative verrucous leukoplakia. Okay, So proliferative verrucous leukoplakia, it is one of the aggressive form of leukoplakia. Okay, I will cover a separate topic that is proliferative verrucous leukoplakia in my upcoming videos. So cervical lymphadenopathy will be present, no nodal metastasis. Okay, as there is no proper invasion, so we won't see metastasis present. So the patient will usually complain of pain and difficulty in mastication. So radiographically, so verrucous carcinoma, it is somewhat locally aggressive tumor. So in the radiograph, what we can see bony erosion if located in the vicinity of the jaw. Okay, so sometimes if they are suppose if they are involving the alveolar ridge area, so what we can see somewhat bony erosion in the radiograph. So now coming to the histopathologic features. So the most important characteristic feature, one of the most important characteristic feature of verrucous carcinoma is the term elephant foot reti ridges. So what does the term mean? Elephant foot. All of us have seen elephant foot, how broad it is. So in the definition, what we have seen, we will see pushing borders, means large reti ridges. In the photomicrograph arrow mark you can see, you will see broad reti ridges, and these broad reti ridges, they somewhat resemble like the elephant foot. So hence this characteristic broad reti ridges are known as elephant foot reti ridges. Okay, so it is characterized by wide and elongated reti ridges that appear to push into the underlying connective tissue without true invasion. So true invasion we won't see. But what we will see? We will see broad reti ridges, and they are pushing into the underlying connective tissue. But microscopically when we will see, we won't see there is break in the basement membrane. There will be intact basement membrane. So a papillary and verruciform surface we will see. Okay, so it we have already read in the clinical features, it is basically exophytic and papillary growth we will see. So histopathology also we will see a papillary and verruciform surface. So the next important point is abundant parakeratin production seen, which fills the numerous clefts and the crypt. That is the parakeratin plugs between the surface projection, which is the hallmark of verrucous carcinoma. Okay, I'll show you the photomicrograph, and what we will see, intact basement membrane. So in this photomicrograph, what we will see? We will see the papillary growth of the epithelium. We will see the papillary growth, and if you see the reti ridges, we will see the broad reti ridges. Okay, in this photomicrograph, what we are talking about, we will see parakeratin plugging. See, arrow mark is given in between the epithelium. What we are seeing? We are seeing a cleft-like structure, and these cleft-like areas, these are filled with parakeratin. Okay, this is what we were talking about. Abundant parakeratin production seen, which fills the clefts of the crypt. It is the parakeratin plugs between the surface projection. Okay, so in the verrucous carcinoma, first important point is we will see the broad reti ridges. We will see intact basement membrane. We will see papillary epithelial growth pattern. We will see these cleft-like areas present in the epithelium, and these areas are filled with parakeratin, which is known as parakeratin plugs. Okay. In the connective tissue, we will see inflammation. So well differentiated epithelium showing little meiotic activity, pleomorphism and hyperchromatism. So we will see very little amount of meiotic activity or pleomorphism or hyperchromatism. Mitosis are rare and located in the supravasal position. Chronic lymphoplasmacytic infiltrate. So in the connective tissue we will see inflammatory cells, lymphocytes and the plasma cells we will see. So when the specimen contains bone, osteoclast may be present at the bony surface, indicating resorption due to tumor invasion. So if the tumor contains bone, what you will see? These bones contain osteoclast. Okay. Keratin masses in the stroma may evoke foreign body giant cell reaction, and if infected, focal intraepithelial abscess can be seen. Okay, so the most important points what we have seen in the verrucous carcinoma is, first important point what we will see broad elephant foot rete-ridges, that is broad rete-ridges which is known as elephant foot rete-ridges. We will see intact basement membrane. We will see parakeratin plugging, which is cleft between clefts we will see, and these clefts are filled with parakeratin, which is known as parakeratin plugs. We will see in the connective tissue, what we will see? In the connective tissue we will see chronic inflammatory cells, lymphocytes and the plasma cells. And these verrucous carcinoma, they will show very little amount of mitotic activity, pleomorphism or hyperchromatism. Okay. So another important point is, at the junction between the normal epithelium and the lesion, verrucous carcinoma normally exhibit an abrupt transition. The inward projecting epithelial force causes a margin of normal epithelium to retract down with them into the underlying connective tissue. Okay, so what we will see? So in this photomicrograph, what we can see the left side we will see the normal epithelium, and on the right side we will see the verrucous carcinoma. So sometimes what it is seen that, see, at the junction between the normal epithelium, and the lesion, what we see? Inwardly projecting epithelial force causing a margin of normal epithelium to retract down. So what we can see, normal epithelium is retracting down with the verrucous carcinoma. Okay, this is one of the another important feature which we usually see at the normal epithelium and the lesion ka junction. कि normal epithelium is retracting down. The normal epithelium is retracting down into the underlying connective tissue. So what are the IAC markers? The IAC markers are PCNA, CD44 and P53. So now coming to the differential diagnosis. First, reactive inflammatory epithelial hyperplasia, squamous papilloma, conventional squamous cell carcinoma, papillary squamous cell carcinoma, verrucous hyperplasia and proliferative verrucous leukoplakia. So if there is no break in the epithelium, it is verrucous carcinoma. So if we see, if there is intact basement membrane, it is verrucous carcinoma. But if there is break in the basement membrane, it is squamous cell carcinoma. It will be known as well differentiated squamous cell carcinoma. So now coming to the treatment, surgical excision without radial neck dissection. So verrucous carcinoma containing foci of conventional squamous cell carcinoma should be treated as conventional squamous cell carcinoma. So surgical treatment can be done. If there is break in the basal membrane, so it should be considered as squamous cell carcinoma. So radiotherapy can also be given. So this is all about verrucous carcinoma. If you have liked the video, please press the like button.